Alright, let's see if my voice is going to hold out after the 4 hours of lecture today. Let's see if we can get this covered before the day is over. We are talking about compensatory responses. You have your inflammatory compensation, and then you have the sympathetic nervous system. Both of these systems try to compensate, have compensation responses. Your inflammatory, we've already talked about. That's when the injury occurs, the healing process gets initiated, capillaries become permeable or they leak. They can't support the vascular system. The WBCs are going to trigger tissue reaction that results, and it's going to cause a major fluid shift that's going to cause edema. And then you're going to end up seeing hypovolemia that lasts up to about 48 hours. Your sympathetic nervous system, you're going to see compensatory responses by increased heart rate, trying to deal with the decreased cardiac output. You're going to see increased respiration, trying to deal with the decreased oxygenation. You're going to see an increase in the metabolism, trying to fix all the injuries that have occurred. And initially, you're going to see an increase in glucose, which is going to caused by the injury itself and the need of the body to supply the glucose for energy. It will eventually go down because we're going to use a lot of it, so we have to be careful to check the levels of glucose. I forgot to put that on slideshow again. How did you girls let me do that? Okay. So let's talk a little bit about the etiology of burn injury. Dry heat, usually from flames. Of course, moist heat is from scald burns or from steam burns. Contact burns, when you touch hot metal. Chemical burns could be wet or dry. Remember, when they're dry, you need to brush off the dry chemical. Do not flush it with water until you get all the dry chemical brushed away. If it's wet chemical, then you need to flush for at least 15 to 30 minutes with either normal saline or water, whichever you have handy. If you're working at the hospital, you can use sterile saline. If you are out in the field and you brushed off the chemicals, or the person has a wet chemical burn, then you can hook up the water hose and hose him down. Electrical burns. One of the things you want to make sure you do with electrical burns is check the heart rate and rhythm. The impulse can interrupt the pacers in the heart. Your current of the electricity is going to follow the path of least resistance. You're going to have a small surface injury and a larger surface injury where it enters, and a larger one where it exits. So you should have 2 injuries. You may have a small injury on the outside, but have large intestinal injuries on the inside. The damage is going to depend on the type of current, pathway, tissue resistance, and of course the duration of the contact. You have radiation burns. That is going to be related to the length of exposure you have to radiation. We all are aware that people who work in radiology have to wear badges that measures the amount of radiation that they have been exposed to, and hopefully that will that's going to be good enough for them to keep them from suffering from radiation burns. But if they have been exposed longer, they need to be sent to the decontamination site because any type of decontamination done needs to be contained, because radiation is very lethal. Inhalation burns, again, you need to make sure that you know to watch for inhalation burns in enclosed areas, house fires. Be sure you're checking their airway. Next up, Don't know why I kept this slide in here, because we aren't really concerned about it. We all know that burns are really a bad deal coming on, so I don't expect you to know incidence and prevalence. Health promotion and teaching. Be sure that we are teaching. We make sure that they have smoke detectors, they have safe plug-ins, they safe use of space heaters. Be sure we're teaching them, you know, not to let their kids play with matches, not to return back to a burning home once they escape. And the main thing with planning, you need to be sure that everyone in the family knows the route to escape from their room, from where they are. And practicing that once a month is really a good thing. You have a page on 473 that's going to tell you the emergency management of burns. And it's just in general. And then you have specific management for these other burns that we need to look at. The very first thing you really want to try to do after you've checked the airway is try to stop that burning process. And you can stop that burning process by applying water from a water hose for 10 to 15 minutes on, and then stop, and then on again. If we can stop the burning process, we can stop the burn, we can stop the tissue damage. We have to be very careful when we're doing this to be sure that we don't make our patients hypothermic. If you look at your chart on page 26.1, it has cover the patient with blankets, raise the extremities if there's no broken bones. With a flame burn, you want to be sure and smother the flames. Remove the clothing if it's not burned into the skin. Again, your chemical burns, if it's dry, you want to brush then flush. If it's wet, you want to flush it for at least 30 minutes. With the electrical burns, we want to make sure that we're trying to break the connection. You don't want to touch a live wire. But you can do this with picking up a stick and removing the live wire from the patient. Be sure you know your CPR and do EKG. So, radiation, got to remove them from the source. And then, of course, we're going to contact the decontamination center and see what we need to do with these patients, because you really can't decontaminate them anywhere except in a decontamination center. Always assess that airway. Do not forget about the airway. If they've been in an enclosed area, be sure you're assessing the for singed nasal hair, drooling, coughing, eyebrows being burnt, and possibly carbon around their mouth. There are certain types of injuries that must be transported to the burn center. Be sure you know these. Patients with known inhalation, such as smoke or flame or steam. Patients with any type of comorbidity, like diabetes. Children who have greater than 10% total body surface area burn. And elderly who have greater than 10% total body surface area. These 4 types of patients need to be sent directly to the burn center. They don't need to stop at the rural hospital. They need to go on. So be sure that you remember or study the types of patients, know the types of patients that need to be sent. The answer to this one is A, C, D, E. The answer to that one is C. And the answer to that one is B, because you want to assess more than every shift. And the answer to this one is C. When you have carbon monoxide poisoning, you have a lack of oxygenation, so your patient's going to complain with headaches. Okay. So, resuscitation emergency phase. This is phase 1. You want to maintain the airway, ensure breathing and circulation. This is always your very first thing you do when you get on the scene. You want airway, breathing, circulation. If we can remove them from the source of the fire to limit the extent of injury, that's going to be great. One thing that we're going to try to be very cautious with is to try to maintain the function of vital organs. This usually occurs in that first phase of burn injury, which begins at the onset of the burn and continues on for about 48 hours. When you have those inhalation burns, remember that intubation is always best done before the edema starts in. So what's a priority expected outcome during the resuscitation phase? The very first thing we need to do is to maintain the airway. The next important thing is we've got to be sure to do fluid replacement so that we can increase cardiac output and be able to give the patient medication for comfort. But first we have stabilizing. Patient develops a new complaint of shortness of breath. This is possibly due to what? A, pulmonary overload. At the site, we're going to be sure that we're going to evaluate the injury, assess our fluid loss, assess the edema, and check it to see where the reduced blood flow. Try to prevent blood flow or reduce blood flow. So, the priority goals in the emergent phase are as listed. Secure the airway, support circulation, try to keep your patient comfortable. And this can be done by doing the stop the burning process, positioning. You may not be able to give them pain medication right away because you've got to have IV access to be able to give them pain medication that's going to work. Prevention of infection, of course, should always be in the forefront of your mind. Maintaining their body temperature, making sure they don't get hypothermic from their skin being unable to hold in heat, and of course emotional support for them and their family. Some things that we would like to know when we get to the scene of the burn victim is the circumstances surrounding the injury, making sure that we know their health history. Be sure that you remember that when you are approaching the scene of an accident or a scene of the injury, safety should be first. Don't put yourself at risk. So let's talk about the respiratory assessment. We want to make sure whether or not there's any direct airway injury, because if we have direct airway injury, we need to intubate. Some of the factors that's going to help you determine inhalations on page 474, table 26.3. So those sort of things are like what we mentioned earlier. You may have nasal septal swelling. You may have nasal hair that's burned. You may have some carbon around the mouth, hoarseness, coughing. So we want to try to make sure that we're looking at all those things. Changes that we're looking for in the respiratory pattern, we want to know if they're having difficulty breathing, shortness of breath, are they having crackles, wheezes, anything that might indicate that they've got fluid overload. Because even before we start resuscitating with fluids, when that fluid shift occurs, then the edema can occur in the lung tissue. So we want to be sure that we're listening for the lungs. If you're able to, raise them up to a 45-degree angle, and supply them with oxygen if you're there with the emergency team to be sure you get the proper help. So, carbon monoxide poisoning. Carbon monoxide poisoning is caused by carboxyhemoglobin adhering to the hemoglobin and displacing your oxygen. That's what causes the cherry red appearance of patients that have this. So your patient's not going to be pale, they're going to be cherry red. And when you suspect carbon monoxide poisoning, you should always order a lab test to check for carboxyhemoglobin. For the pulmonary, I didn't mention, I want to go back and mention, not only do you need to listen to the lungs and what's going on the inside, you need to make sure what's going on the outside, such as tight eschar around the chest. If you have tight eschar around the chest, that prevents the chest from expanding. Then you need to be sure and do an eschorotomy, which you are going to cut down each side of the chest to try to cut through the dead tissue there so that they'll be able to breathe. Again, remember that the extent of the injury is going to depend on the fire source and the duration. So be sure you're watching for changes in the breathing pattern. Watching for that hoarseness, the brass cough, the drooling, the expiratory wheezes. You may need to, you may not know that there is an inhalation injury, but if you're having all those symptoms, you're pretty much certain that they had an inhalation injury and you need to intubate your patient. So now let's talk about the cardiovascular system. Shock's going to be your major cause of death in this resuscitative phase. Your patient develops hypovolemia, and of course with hypovolemia comes decreased cardiac output. We prefer invasive blood pressuring if we can, because it's not going to be accurate. If you've got burns on the arms, then you can't, it's not going to be very accurate about what your blood pressure actually is doing. EKGs are really great to use with those that have had electrical burns, because we're worried about their heart rate and rhythm. So just in review about how the body responds when the first burn occurs, is that when the burn is going to occur, then you're going to have the vasoconstriction, which is your histamine effect. Once the vasoconstriction occurs, then we're going to see dilation of the vessels, which causes the capillaries to leak, and bringing the blood to the injured site so it tries to heal it. Because of the capillary leaking, we're seeing all this fluid is going to be third shifting. So it's going to shift from the vascular space to the tissues, to the interstitial spaces. When that shifts from the vascular space to the tissues, then we're going to see hypovolemia develop. We're seeing a loss of fluids from the leaking, from the injuries, and from the third spacing. We're going to see the hematocrit increase because of dehydrated state of vascular system. We're going to see the hemoglobin increase, metabolism increase, oxygen's going to be used up, so we're also going to see glucose increase. So once the oxygen's used up, we will see a decrease in the hemoglobin. Alright, let's look at renal. It's very important to assess for our renal, because if we have kidney failure, the rest of our body's just toast, okay? No pun intended. So when you're assessing the urine, be very careful that you're assessing the output. If we have a urine output less than 20 milliliters per hour, or if we have greater than 300 milliliters per hour, that should be a big red flag to you. If it's less than 20 milliliters per hour, then we're not giving enough fluids, no matter how much fluids we need. So we need to give more fluids. Even if we're giving 1,000 an hour, if we don't get 20 out, we need to increase it. If we have greater than 300 milliliters per hour, that could indicate renal damage. Your urine's not being concentrated. It's just sailing right through there, and not the kidneys are having a lot of renal damage. So you want to be sure you're doing accurate outputs. You'll probably want to put a Foley catheter in, and of course we're going to see a decrease in that first 24 hours because we have that third spacing. We're going to that third space. So we want to be sure that we are measuring it. We want to try to maintain fluid resuscitation at a rate to maintain the 30. So whatever it takes, and it's going to be a high amount. We should be monitoring the BUN, the creatinine, and the sodium. And of course, in that first 24 hours, our sodium is going to be hyponatremia, remember. Creatinine is going to tell us if there's any damage to our kidneys, and then the BUN is going to help us decide what we need to do as far as the rest of it goes. So it's not going to be a good thing if we're exceeding 300 milliliters an hour, especially in this phase. Our kidneys have shut down and we're just not, things aren't working as they should. So remember that when our fluid shift occurs from that permeability of the capillaries, no fluids are going to the kidneys for them to secrete out, and there's no blood supply to the kidneys for them to maintain their function. So the thing that you're looking to see is decreased urine. You're not wanting to see an increased urine, but you've got to have at least a minimum of 30 to assure that your kidneys are working properly. Skin assessment. Know your rule of nines. You must be able to calculate the total area burned and fluids need. The total surface body area is necessary to estimate the body surface area of the burn. We need it so we can do diagnosis, prognosis, but it's especially important for us to know at the very beginning of our phase 1 resuscitation phase for fluid replacement. Big thing for fluid replacement. We'll also need it for drug calculation and calories, but right at the very beginning, fluid replacement is what is going to affect us the most. And I really don't care if you know about the laser Doppler or not. It's just that you can use it to be more precise. But in the phase 1, you're usually having to do your best guesstimate. So I put this little chart in here, although you do have this in your book, and it shows you the rule of nines for an adult. The head, a total head is 9%. So if the front part burned, it would be 4.5. The back part burned and not the front part, that would be 4.5. If the whole head burned, it would be 9. So be sure you know how to figure this out. Anterior trunks, 18% front, 18% back. Both sides of the arms are 9%, but half of it is 4.5%. Lower extremities are 18%, and the front part's not. If it's just the front part, it's 9%, and if it's just the back part, it's just 9%. But if it's total, it's 18%. Okay. So, and then of course 1% for the perineum. With our babies, the things that are different is that the head is 18% because they have such a large head. Anterior still 18%, as is the posterior. Arms are still at 9% because their arms are kind of long and hang down like little monkeys. 1% on the genitalia. And then the legs, because they're short and squattier than in proportion to the rest of the body, they only get 14%. So be sure that you know these rules of 9 and be able to figure out how to do it. So Mr. Smith's found alongside the burning car. He has burn injuries that are covering both arms, front and back. We also have the front torso and the front part of his leg. So, what's the surface area burned? Both arms, 9%, times 2 is 18%. The torso, just the front torso, is 18%. His left leg, just the front of his left leg, is 9%. So his total burnt surface area is 45%. Joe was thrown out of the car, but he pulled Mr. Smith out of his burning car. He has burns on his face, and his hair is singed off. Both arms are burned as well. What percent does he have? Well, if he's got all of his hair singed off and his face is burnt, that tells you his whole head was burnt. So that's going to be 9%. If that had been a baby, it would have been 18%. Both arms are burned as well. So both arms, 9 times 2 is 18. It's 27%. Let's talk about gastrointestinal assessment. I want you to be sure that you know that we're looking for paralytic ileuses and Curling's ulcers because of the decreased blood flow and the sympathetic stimulation that's going to occur during that resuscitative phase. Bowel sounds are going to be decreased. We're going to see distension. We really should put an NG tube down for any patient that we've got intubated or that has more than 25% burns on their body. So, the answer to this one is C. Now let's look at some lab assessment. We've already talked a lot about our lab assessment. We know that venous blood analysis is going to reflect that fluid shift and the tissue damage that occurs. Our WBC is going to first rise in response to the inflammatory response, but once they are used up, they are not replaced quick enough, and you will see a fall down to possibly 2,000 WBCs. So septic can be the low WBCs. We're going to see a shift to the left in their immune system is unable to sustain the defenses. Our H&H, of course, is up due to the vascular system being shifted over into third spacing. Sodium decreased, hyponatremia, potassium increased, hyperkalemia. There's other labs in the book on page 477 if you would like to look at them. Cultural considerations that we need to think about in this resuscitative phase, especially with lab, is we might want to do a sickle cell trait test on our patients who may be presenting with sickle cell, and we don't know if they have sickle cell, but we have a very high suspicion about them having sickle cell crisis going on, because these patients we're going to need to really do an exchange transfusion. These are the only burn patients that we will actually start out giving them blood instead of lactated bringers, simply because of the damage to the sickle cell is going to occur, and we need all the oxygen carrying capacity we can get of normal red blood cells. So you're caring for a patient, 30% body surface burn during the first 12 to 36 hours. What are you going to see? Due to the capillary leak, you're going to see tachycardia and hypotension, so that should be C. You do not expect to see hypertension, do you? Because we are not going to have, we're going to see hypotension. You're not going to see bradycardia because we're going to have tachycardia. You're going to see hypotension because of that. Now, respiratory depression and lung crackles, we don't really expect to see these. We're hoping not to see these, but the one things that we're really looking at are going to be the tachycardia and the hypotension. The RN is caring for several patients on the burn unit. What you're going to monitor, what electrolyte imbalance are you monitoring for? Well, hypercalcemia we haven't even talked about, so you shouldn't even consider that one. Hypernatremia is not true because the sodium's moved over into the interstitial spaces. Hypokalemia, that's not true because we have a lot of calcium or a lot of potassium running around in the vascular spaces, which causes hyperkalemia, which is D, so that's the answer. And which one of these is is related to vascular dehydration? You're always going to see a concentration of your hematocrit or your hemoglobin, and the only one of those that's increased is A. These are some of the nursing diagnoses that you're going to be expected, that you may see, not that you're going to be expected to know, but that you may see with a burn victim. So it can decrease cardiac output and deficient fluid volume kind of go hand in hand along with your ineffective tissue perfusion. So you have a lot of possibilities for diagnoses. Whoops. So decreased cardiac output and deficient fluid volume, ineffective tissue perfusion. What are the nursing diagnoses that we want to, our outcome that we are going to tell ourselves is that we want our patient to have our cardiac output restored to normal. That's going to be our short-term goal. We want that patient back into having cardiac output. So how are we going to fix this? We're going to increase the blood volume by doing fluid resuscitation, supporting those compensatory mechanisms, and preventing complications that may arise during that process. Now we get down to our non-surgical management, and what we're going to see with that is that we're going to do IV therapy and drug therapy. The biggest thing that we're going to do is the fluid resuscitation. So you got a chart in your book you can look at, 26.4. Instead of me reading all that to you, you can read it to yourself. Know your Parkland formula. This is 4 milliliters of fluid, which the fluid is going to be lactated ringers, times the kilograms of the patient. Sometimes it has to be an estimate because you don't always know how much a person weighs, and he may not be able to tell you, times the percent of the burn. So that's the formula. You will have to remember the formula. It's going to be the same for an adult as it is for the child. And what you need to remember about the formula is it's going to be a large amount of fluid. So when you see this large amount of fluid, don't think that you're wrong. Okay, let's go back to Mr. Smith. He weighed 220 pounds. That makes him 100 kilograms. So 4 milliliters times 100 kilograms times 45% of the, and the 45% is no decimal places. You just multiply it times 45. So it will be 4 times 100 times 45. That will be how it will be. You will come up with 18,000 milliliters of fluid that he should receive over a 24-hour period of time. The first 8 hours, he is to receive half of that 18,000. So he will get 9,000 milliliters of fluid in the first 8 hours. You have to calculate the first 8 hours from the time of the burn. So if it's been 2 hours from the time of the burn before he gets an IV started and gets the fluid resuscitation started, that 9,000 milliliters of fluid would have to go in within 6 hours. And on top of that, we have to make sure that we're still getting 30 milliliters of urine out per hour, or we may even have to increase the fluid for more than that. So he's going to get 9,000 milliliters, which is half of the 18, and for the first 8 hours, and then the next 16 hours he will get the other 9,000 as long as his urine stays up. Anytime a client is burnt more than 20%, they've got to have IV therapy. It is a large amount of fluid in a short period of time. So, that's why we have to be careful with pulmonary edema. We want to make sure that we are not causing more problems than what he already has. I've already covered the calculation time begins at the time of the burn. So Mr. Bill here was burned in a fire at 2200. The paramedics picked him up at 2300. So they estimated he had 50% burns and he weighed 80 kilograms. How much fluid should he receive in that first 8 hours? Well, in the first 8 hours, we're going to say that 4 times 80 times 50 is 16,000 for a 24-hour period. Then we'll give 8,000 in the first 8 hours. However, we are 2,200 before an hour has gone by. So he will receive that in the first 8 hours if we had 8 hours. But it's 8 hours from the time of burn, so we're actually going to have to set our pump for that 8,000 to go in 7 hours. So you'll have to give it in 7 hours. and it's a lot of fluid, but they need a lot of fluid because they've lost a lot of fluid. Be sure we're monitoring the patient for the adequacy of fluid resuscitation, which means that we want to make sure we're getting 30 mils per hour of urine. Titrate the fluids as we need it. We do not give diuretics. They don't increase the cardiac output, but they do decrease the circulating volume, and we definitely are not going to give them any diuretics. We might give them some medication that might help increase their heart cardiac output, but we're not going to give them diuretics. The only exception to that rule is with an electrical burn. We can give osmotrol. Okay? If we have to, if lactated ringer is not working, we can do a plasma exchange. We can remove plasma from the patient and replace them with fresh plasma, which is a plasmapheresis. Or like with our little sickle cell fellow, we can remove the blood and replace it with whole blood. The eschorotomy means cutting into the eschar, which you will have to do if it's around the pulmonary, around the chest. You're going to see ineffective airway, or ineffective, not airway, but ineffective breathing pattern. Airway has to do with the actual trachea. So this would be ineffective breathing pattern if the eschar is around the chest. We can do a fasciotomy, which is an incision into the fascia, if doing an eschorotomy does not relieve the pressure and allow us to have good circulation. So our ineffective breathing pattern is a nursing diagnosis. We want to be sure that we maintain airway with effective breathing. That's our goal. It begins at the scene. It may involve just a chin lift. It would be different if we had inhalation. We would need to intubate. Okay, place an ET tube. You may need more than a chin lift. If you need more than a chin lift, you would need to place the ET tube in. Because facial burns, even if they're breathing okay, once that fluid shift occurs, swelling's going to happen and we're going to have the airway blocked. So that is when that would be different. Of course, we're going to promote ventilation, make sure the skeletal muscles move. The eschar would be what would maybe prevent that. And hopefully, we'll have good gas exchange with our patient. Be sure you monitor for cyanosis, disorientation. Of course, your pulse rate is going to be increased. If we have to give oxygen, we'd like to have it humidified. Anytime their arterial gases are less than 60, they're going to require ventilation. We only give antibiotics if pneumonia is actually present. We don't give them unless we do see a bacterial infection occurring. Cardiac drugs will be given to improve cardiac output if we have to. And paralytic drugs will be given if we need to help them tolerate the pain and the positioning they're in. Of course, we want to be sure that they're positioning and they're deep breathing accordingly. We want to be sure that we put splints on joint areas so that they don't become contractured. Some of the things that we may have to do surgically to manage the airway is a tracheotomy. We may have to put in chest tubes, and of course, we've already talked about the eschorotomy. So what about our nursing diagnosis of acute pain and chronic pain? Well, we hopefully be able to control the pain. Usually we give IV morphine to adults and children. We can give Versed and fentanyl or Demerol as long as it's an opioid. But we always want to make sure it's IV, whether it's opioid or non-opioid. If you give it IM, it's not going to disperse the way you want it to. You don't even know how those tissues have been affected by the burns. And it either will be ineffective, or when the fluid resuscitation when the fluid redistribution starts to occur, you can overdose them. So you want to make sure that you're aware of that possibility. Again, of course, be sure we're checking for that pulmonary edema. We can give digoxin, but we have to give it with caution. And the only time we give the diuretics again is with an electrical burn, or when they're in the phase 2 and they're out of danger of depleting their vascular fluids. Don't forget that the first sign of fluid overload is confusion. You don't want to turn the fluids off, you want to turn them down. So confusion and lethargy, you need to be watching for that, especially in children. Okay, let's say the patient sustained 37% burns and we started him on fluids. What information do we need for this formula? We need to know how much he weighs. We already know what his burn is, so we need to know how much he weighs. What type of fluid is administered? Lactated ringer. We certainly don't want to get normal saline because we already have a problem with salt being hyponatremia. It's shifting to the third space, so if you give normal saline, it's just going to shift more to the third space. So if we're going to use the Parkland formula, we're going to do 4 milliliters times, he weighs 176 pounds, so that's 80 kilograms. So 4 times 80 times 37. Remember, it's not point, it's just 37. So the amount of fluid we need is 11,840. So remember, there are large numbers, so don't be tempted to put a small number. It's in the thousands. These are our laboratory results. We have a high hemoglobin, we have a high hematocrit, we have a high glucose. Our BUN-urea is not looking, our BUN is not looking all that great. So how would you interpret these values? It's looking like we have fluid volume deficit, right? We have a high H&H. Our glucose is up. He may be in metabolic acidosis. So our next step would be to try to get him hydrated. What other clinical indicators would you use to assess the adequacy of the fluid resuscitation? Of course, our urinary output is going to be one of our major factors. We can't really check skin turgor because our skin is damaged. So we need to be watching out for that. Mucosa being moist and not dry. But our main thing is going to be urinary output. So what is the most likely cause for that elevated blood glucose? It's the damage to the skin tissue. Our metabolism is up, and so the body produces more glucose to try to manage the needs of the body and the energy that it's going to take to fix it. All right, now we're to the acute phase, or the phase 2 of the burn injury. It could be begin around 38 to 48 hours, depending on how long it takes to get through phase 1 or resuscitative phase. It's going to last up until the wound closure is complete. Once wound closure is complete, then the rehabilitation phase starts. Care is going to be directed toward continued assessment and maintenance of the body systems. Pain control, prevention of infection. And infection is one of our biggest concerns in this phase, whereas the other phase we were concerned with ABCs and fluids. Wound care, nutrition, and psychosocial intervention. So our priorities are going to be, number one, to prevent infection, prevent loss of body heat, to prevent hypothermia, splint position and exercise our joints to prevent contractures, and be sure we're providing for pain relief. So these are all the things that we are going to be doing for this patient. And of course it requires, because of all the body systems that are involved, it's going to cause a multiple, we need a multiple disciplinary approach to that. Nursing diagnosis of impaired skin integrity, or our interventions here is going to help. We want to try to preserve the integrity of the non-burn skin, enhance the healing of the burned skin, and prevent any complications. And of course we're going to try to remove excessive exudate and necrotic tissues. We're going to keep our area clean to stimulate that granulation and revascularization. Now you've heard this before. This is what we do with a pressure ulcer. So any type of wound that has this particular type of involvement of the depth of the skin and what the dermis and the epidermis and the subcutaneous tissue, all going to be about the same type of care. Of course, when we start removing the debris, restoration is going to, of the skin is going to start when we get rid of all the debris or the dead tissue that's in the wound. We've already talked about debridement, which is just the removal of the debris in the wound. We want to have the wound prepared itself for healing by a natural process. So we can either mechanically remove it with scissors or scalpels or whatever, or we can use enzyme to break down the tissue and it turn into exudate and come out. So how are we going to dress our wound? We can have homografts, heterografts, amniotic fluid, cultured skin, artificial skin. We can have mesh skin. We can have biosynthetic dressings. We can have synthetic dressings. We can have all these different types of dressings that we can use for the burn. The biological dressings are actually the best as far as promoting growth of epithelial cells, because it maintains a moist environment and it protects the wound from outside contaminants. Your biosynthetic dressings don't work quite as well. Your synthetic dressings are very expensive, so they try to use the biological more so than the others, depending on where they need to place the graft that they are looking to place. When you do a dressing change on a wound, be sure that you do not cross-contaminate, that you always change your gloves, throw away all your debris and stuff before you go to the next wound on the same person. It's just like you have a different person for different wounds. Your donor site is going to be much more painful than the graft site, where you're going to put the dressing or the graft. So we don't need to forget that our donor site is very painful. Remember, we need high calories, high proteins. Greater than 5,000 calories is what we need. We want to feed them orally if we can, but we can actually need to start enteral feedings as early as 4 hours. So, some of our surgical management, we can do surgical excision, and some of your doctors will do that right away instead of waiting for the wound to heal itself. I don't expect you to know exactly, we're going to do the fascia excision where we're taking away the fascia, but the tangential technique is interesting in that they actually just shave off layers of necrotic burn surfaces until bleeding occurs, and they assume that they have reached viable tissue. So again, let's be sure we don't auto-contaminate or cross-contaminate by not washing our hands, using our gloves, and changing them in between dressings. We want to prevent all types of infections that we possibly can. Be sure that we give that tetanus shot if they haven't had it within 5 years or if they don't remember. We can put topical antimicrobial drugs, but we're not going to give systemic. Silvadene and sulfamylon should not be applied to grass because it will prevent them from actually adhering to the tissue. We only give antibiotics when we have an infection that's systemic. Then we do blood cultures. We try to make sure what drug is going to target that one. You have to give larger than normal dosages required. And of course, the chart on chart 26.5 gives you a lot of gives you the examples of drug therapy. You need to take a look at that. Safe environment. We want to keep our patients in isolation therapy. In our burn units, they're always in reverse isolation. Be sure we're using aseptic. We don't usually use sterile until we get to right down to we use wash our hands, put on a pair of regular gloves, remove the old dressing, wash our hands, have our stuff all, have our sterile supplies open, the gauze and whatever we need to do our wound care, have that open, put on sterile gloves so we can try to keep that contamination down. Once we get all that cleaned, we take off our gloves, we put on a pair, wash our hands, put on a pair of clean gloves, apply the new dressing, take off those gloves, wash our hands, and start all over again with the next area. Early detection of infection is key to preventing a lot of our problems, and we may have to do surgical management with that. We have to be sure we have balanced nutrition, because imbalanced nutrition is one of our nursing diagnoses. Of course, our goal is adequate nutrition. We should give at least 5,000 or more calories. Remember, we talked about how much calories we needed for positive nitrogen balance. We need 30 to 35 calories per kilogram per day to maintain just a positive nitrogen balance, which is important in tissue replacement, tissue repair. Nutritionists should be consulted. We should not be giving them oral until the GI tract is mottled. So we should be having peristalsis. We should be hearing bowel sounds, passing a gas going through before we start letting them eat orally. But we do need to start enteral feedings as early as 4 hours to try to prevent weight loss, the gut atrophy, and bacterial translocation. Our nursing diagnosis of impaired physical mobility. Of course, our goal is going to be to regain and maintain mobility. We should never allow two burn surfaces to touch each other. Look at the chart on page 487 that shows you all the different positionings that we can use for the different burned areas. The main areas of concern is going to be the over the joints and the so that we don't have contractures develop. We're going to do range of motion. We're going to try to emulate them as soon as possible. The pressure dressings are going to help with preventing scarring. These are where you have elastic wraps around the burn area, or you have a full elastic bodysuit or pair of gloves or boots, wherever the burn is. It causes that to have pressure during the whole time they're trying to heal. These have to be worn 23 hours out of 24, much like your scoliosis bracing. Surgical restores mobility, but it's not going to prevent the contractures from developing. It's just going to help restore what mobility they have by doing a release of the contractures. So it's not going to cure things, but it's going to help things. Disturbed body image. How are we going to work with that disturbed body image? Of course, we want our patients to have a positive perception. That's our goal. We know they're going to go through stages of grief. We may have to get them a grief counselor. We need to have maybe a plastic surgeon come in and talk to them early on. we have to be accepting of the patient's features. If we go in and they can tell by the look on their face, on our face, that we think they look grotesque, then that's definitely going to give them a negative body perception. We want to be realistic about what they can expect. Some burns are not going to heal. They're going to be scarred. The faces may never be able to be back to the way they looked before. And that's pretty much a given with most burn patients. There are going to be some scarring. Let's don't set them, tell them, oh yeah, you're going to look just like you did before the burn. We want to be realistic. What we can do that's going to be an attainable goal for this patient. Let them have self-care. That's make decisions. That's very important. And of course, our reconstructive surgery that's available. We need to have a plastic surgeon come in and look at that for them. Okay, we have finally reached phase 3, which is the rehabilitative phase of the burn injury. Technically, rehabilitation should start at the very beginning of the burn process, but we are going to technically say that rehabilitative stage starts with the beginning of the wound closure, and it's going to end when the patient returns to the highest possible level of functioning. We can't say as they return back to the functioning they had before the burn, because they will probably never be able to reach that function. And so we want them to return to the highest possible level of function before we turn them loose out of rehabilitation. So what we're going to be looking at is the adjustment of the patient to what damage has been done, the prevention of scars and contractures, and then being able to resume a life. It's going to be hard to go back out into the world with scars all over you, and burns are very angry looking scars. Okay, so consideration of burns that we have. Psychological care, of course. They may have PTS. They may have sexual dysfunction due to, if they can't accept the way they look, then they know that they're going to think nobody else does, so we have sexual dysfunction. Some of our patients are going to become severely depressed. So, specifically, reactions of others to the disfigurement is going to affect them psychologically. They go through a variety of stages. I'm not going to expect you to go through all those stages. Be sure you look at the home care on table 26-7 to look at what you need to address before you send them home. Make sure they have what they need there to be able to continue their home care. So be sure we're doing our health teaching and any resources such as support groups, health teaching, how to prevent infections, how to make sure you take in nutrition. Be sure that we are doing all the things we need to do, and that's actually listed in that chart. So let's talk about some pediatric considerations. Now, I told you we had to read the certain pages in the pediatric book. So let's just look at the pediatric considerations. This is what I pulled out. This is about the correct amount of information you need to know because of the amount of pediatrics in relation to the NCLEX is not as high as it is for the adult. Anytime they have a burn of 10% or older or 10% or greater, they need to go to the burn center, remember. From the musculoskeletal peds, you know that the child usually heals much faster than adults, so they usually are going to bounce back from burns quicker than an adult will. An infant's skin is much thinner than a child is, so they may have the same burn, but it'll be a deeper tissue injury on an infant. Our children usually die from pulmonary problems that develop with the burns. We should always make sure that they get their tetanus shot as well, especially if it's been more than 5 years since their last injection. Again, same as with adults, if you anticipate edema around the neck and the face, you need to intubate to protect your airway. Our fluid resuscitation, our fluid replacement, we have objectives that we want to reach. We want to compensate for that water and sodium loss because remember we have fluid going over in the interstitial spaces, and we have the sodium going over there with that fluid. So we have hyponatremia and hypovolemia. So our objectives are to replace that fluid to compensate for water and sodium loss. We want to reestablish sodium balance so that we get the sodium back out of the interstitial spaces and into the vascular spaces. Of course, we want to restore circulating volume. We want to provide adequate tissue perfusion. We want to correct the metabolic acidosis, because it is metabolic acidosis, and we want to make sure that we're improving the renal function by making sure that we have enough fluids going to those body parts. Nutrition, children have a very high metabolism, and of course we know that burns cause the metabolic rate to go up. And that's going to cause your protein breakdown, which will give you the negative nitrogen balance. We want to make sure that they have high calorie, high protein diets. And of course, tube feedings until we can make sure that they don't have a paralytic ileus occur. As far as medications go, treating the pain, morphine again is the drug of choice. IV is the route. They like to use Versed and fentanyl as well. Silver nitrate we will put on topically. Bacitracin is topically. Again, no antibiotics unless there is a sign of systemic infection. Children less than 48 months or less than 4 years old have a very high mortality rate because they have such a large skin surface area that can get burnt. They go through the same stages and phases of burns as the adult do. Our IV infusion regulates to maintain. I'm not going to expect you to know this, but we should, over 30 pounds, expect 50 milliliters per hour. Always assess that urine output carefully. If your output exceeds 100 milliliters per hour, if your output exceeds 100 milliliters per hour in that initial phase, and the urine is clear in color, that could indicate renal failure. So be sure that you're watching for urine exceeding 100 that's clear in color, indicating renal failure. When the kidneys are doing what they're supposed to do and concentrating the urine, it should be amber and not clear. They, of course, are at very high risk for hypothermia. We want to make sure to keep their room warm, dressings warm. Any type of fluids we use to clean them should be warmed. Of course, watch for the respiratory changes in a child. We're going to be watching for restlessness, irritability. You may see the intercostal retractions. You may see or hear grunting or nasal flaring. So you want to be sure that you are monitoring that. So how are we going to prevent all those complications we just talked about? Maintain that body temperature. Be sure the environmental temperature is around 82 to 92 degrees. You're going to have a really hot room to have to work in as a nurse. All your solutions should be warm. Linens, dressings, heat shield, all these things should be considered as far as keeping those areas, keeping the area around them warm. Cover those surface area burns. Prevent infection by good hand washing. Allow the child to participate in that care as much as possible. Give them a little bit of control. Let them help you remove the dressing. They can help you put on the topical ointment. Again, be sure that no two burn surfaces are touching, especially your joints. Know your symptoms of sepsis, the change in level of consciousness, and this sounds an awful lot like what we talked about with an adult. So we're going to see tachypnea, tachycardia, hypo or hyperthermia, an increase or decrease of the WBCs. And again, we want to prevent those contractures, so we need proper body alignment. Be sure that we're splinting those joints and that we're doing active or passive range of motion with our patient and doing our positioning as we should. Once we get the wound coverage achieved, once it's has closed, we're going to start the rehabilitative phase. Some of the things that scarring causes is itching, contractures, and deformities. If we apply a uniform pressure then we can help decrease scarring. When the pressure is released, blood supply increases to the wound, and it's going to cause increased scarring. So that's why you have to wear this 23 out of 24 hours a day until the healing is done. Family support, and us, we need to support the family, as well as family needs to support the little patient. Prevention of burn injury is the most important thing with children, rather than try to fix them after they're burned. Most children are burned because of carelessness of adults that allow them to get into areas or have access to things that will cause burns, such as chemicals, matches, space heaters. Sunburns are really common with children. My 2 grandchildren have sunburns as of today because they went to the river yesterday and stayed out in the sun and in the water. So they're all both complaining about how bad their sunburn hurts. They probably should have had some topical sunscreen and blockers, but they went to the river during the time that I wasn't there. Your children should be over 6 months old. If you have a child that's less than 6 months old, you do not apply sunscreen. You just cover them with clothing and keep them out of the sun. The end. Woohoo! I bet y'all are glad.